Hello and welcome to Scottish Planner Live, a transformation of what was the old RTPI Scottish Annual Conference. We have a series of 10 short online sessions running over the course of this week. The topic for the whole week is how we embed healthy places and how we plan for those healthy places. And specifically today we'll be looking at how we assess the impact of development on health, looking more specific at that evidence and what are the aspects that we should be assessing. My name is Irene Beautyman. I'm convener of RTPI Scotland during 2020. My background is also working for the Improvement Service, so working with local government across Scotland on the delivery of its national outcomes. And I also spend part of my week with Public Health Scotland as well, working with many experienced practitioners in that organisation who work on the role of place and how it enables health and well-being for the people of Scotland and its contribution to those national outcomes. So this topic for the week is very much my passion. I very much work around place and the role of planning in that place because, as we know, place is about, for planners in particular, it's that physical aspect of the environment, but then how that impacts on people and how that impacts on our economy. And those three characteristics are there in every part of Scotland, despite the fact that we have so very many varied and different places and environments to deal with and to plan within. We have our intended consequences of our actions, and place-based working is all about making sure that any of the unintended consequences are positive rather than negative. Scotland at the moment has a pretty poor health record across the whole of Western Europe, with massive inequalities. So whilst health is improving for many of us, the disparity across deprived and non-deprived areas ranges from between 22 and 26 years, which is pretty abysmal, really. So that's the focus of this week, really. What is planning doing as its contribution into that? It's not the only contributor, there are so many others. And over the course of this week, we've already heard from many in local government, in health, and within the profession as well about their contribution into that. It's been an interesting week so far, where we've been reflecting upon the big road to Damascus moment, as I'm now calling it, copying from Angela Scott at Aberdeen City, is realising that the defined social determinants of health are the conditions and the circumstances in which people live, work and play. And if you're a planner, you sit and go, oh, but that's what we do as well, isn't it? The two link together. We have that shared ambition. So we've had a lot of conversations to date this week about that bigger focus on working together around a set of themes that's the kind of topics that are embedded in the background to the Place Standard tool. We've had a lot of conversations around a 20-minute neighbourhood because if those themes are actually delivered upon in an area, then you would pretty much be delivering a 20-minute neighbourhood. We heard from the Minister about his 100% support for 20-minute neighbourhoods and for strengthening the arm of planning to deliver healthy places. And we heard about the sweet spot of density, how important that is in a mix of use, land uses and connections, and that climate and health very much knit together when we're looking at planning's interventions. So we ended yesterday looking at a bit of getting into detail, I would say. We started big, we got down into a bit more detail about the kind of changes that we really need to be thinking about. A prescribed density was suggested, local schools instead of big campuses, walkable communities, and looking at the walkability of people's daily access to amenities and services. Whilst we accept that there are weekly and monthly journeys we may always take that are beyond that, how much can we achieve locally? So we very much were drilling down into that local area. So for today, though, we're very much then looking at how do we actually assess that? If we're looking at a change in an area and an environment, then how can we sit down and think, well, what's the impact of this change going to have on health and well-being. So we will be focusing down. The Planning Act introduced a requirement to assess the impact of health on national and major developments. So this is coming our way. There'll be regulations to follow, and this is very much an initial conversation where I'll be joined by two speakers who are heavily involved in impact assessments around health already. In a moment, I'll be introducing Margaret Douglas, who works with Edinburgh University on a Master's in Public Health. She's a co-director there. She's also an honorary consultant in public health and leads the SHIAN group, which is a network that deals with impact assessments on health as well. So very well set up within Scotland, but has, crucially, gone in and worked with a planning authority on developing just the kind of impact assessments that we are considering today. So Margaret will be sharing where we are on that journey in Scotland, and then we will come to Helen Ashby-Ridgway, who works for Lichfields and works in both Wales and England and has already been completing health impact assessments within the different legislative system that exists in those countries. So she'll be able to share her reflections and experience so far in her involvement in producing those, and her thoughts on where planning in Scotland could pick up the good and perhaps overcome some of the challenges as we enter into this journey. When I was saying about all of the sessions, just to be clear, we're recording every session, and at the end of this week you will all be sent out a link. So if there's anything in today's session you wish you could watch again, or you're thinking, gosh, I wish so-and-so was watching this, then look out for that email. It will come in, and you will be able to review all of the sessions and send them on to others. So that opportunity is there. The other opportunity is we will be switching partly through to an opportunity for questions. So a Q&A panel will come up in front of you. Please submit your questions as early as you can, because that last little area of time runs away with us every single session. So I urge you to get your questions in as soon as possible so that we can have a bit more of a chat. We will manage to take 2 or 3 usually. So without any more ado then, I'm going to hand over to Margaret Douglas, and we'll have a look at measuring that impact of policy and practice and what's happening, what's the story so far within Scotland. Margaret, over to you. Thank you.
Thank you very much indeed, Irene, and thank you very much for inviting me to be here. I've been really enjoying this series of webinars, and it's a real honour to be able to come along and contribute some of my thoughts this morning. As Irene said, one of the things that I do is I chair the Scottish Health and Inequalities Impact Assessment Network, and our network aims to promote a health in all policies approach, increase the use and quality of health impact assessment, and also improve the coverage of health and other forms of impact assessment in order to improve health and reduce health inequalities. I've been working on health impact assessment for about 20 years now, which makes me feel really quite old. And I've worked on the development of guidance, resources, and doing health impact assessments in various sectors, including planning. So it's fair to say I am quite an enthusiast for health impact assessment, but I see it very much in the context of a broader health in all policies approach. It's very much about working in partnership. So this morning I'm going to say a little bit about why I think it's important to assess the health impacts of developments, in particular planning applications. Say a little bit about the approach to health impact assessment, who needs to be involved, and give an example from my own experience. So the first and perhaps most obvious reason that we need to assess health impacts is there is now a requirement to do so, as Irene mentioned. The Act requires that national developments and major developments should have an assessment of the likely health effects before planning permission is granted. And also, the NPF outcomes very clearly identify that one of the major outcomes of planning should be the health and well-being of people living in Scotland, and also improving equality and eliminating discrimination, which is also something that we're trying to promote within health impact assessment. So there's some formal requirements for HIA, but much more fundamental and much more important, of course, is, as we've been hearing so much this week, place has very many effects on health and well-being. And of course, as we've also heard this week, planning decisions will affect health not only now but for future generations. And as Irene said, the things that make the biggest difference for health and well-being of people in Scotland are not the things that the NHS controls, but the places where people live, work, grow and age. And they're much more important than the health services that pick up the pieces when they become ill. The image on the left shows the health field model, which was developed by Marcus Grant and Hugh Barton, whose backgrounds are in planning and in landscape architecture. And they adapted a very well-known model of the determinants of health to show how the natural and built environments that we create affect the activities that people do, the economies they work within, the communities they interact in, and these all affect health, both through health-related behaviours, but also directly. In public health, as Irene said, we call these the social determinants of health. But of course, in planning, you're very familiar with all of these aspects of place. And on the right side of the slide is the place standard, which identifies the 14 dimensions of a place, all of which have very strong evidence of their links to health. So clearly, planning decisions affect all of these. But there are so many ways in which a planning development can affect health that it can be really quite overwhelming. On the slide is basically a brainstorm for a residential development showing the wide range of possible impacts that this development could have. And it could have positive impacts on some of these determinants and negative impacts on others. So to have a rounded understanding of the overall health effect, we need a systematic approach to identify which of these is most relevant for a particular application. And in addition to that, these different impacts will be felt differently by different people. So the residential development might affect the health and well-being of the people who will eventually live there, the people who already live nearby, people who work there, either on construction or subsequently, and people who use services and amenities, either the existing services and amenities or those that are developed as a result of the residential development. And all of these people may be old, young, male, female, able-bodied, disabled. All of these groups will have different needs. And this means that the places that we create are also important in either increasing or reducing health inequalities. There's a very well-established process for health impact assessment, which is similar to other forms of impact assessment. The document on the slide is our guidance from our SHAN network, which is available on our website, but follows the same process as is used around the world. These are the commonly defined steps. First of all, screening to determine whether a health impact assessment is needed and would be useful. Scoping to define the impacts and the kinds of evidence that should be gathered to understand the impacts. Appraisal, which means gathering all the evidence together. Making recommendations, reporting on the findings, and finally monitoring and evaluation. A good way to scope the relevant populations and relevant impacts is to use a checklist and involve a group or several groups of stakeholders in a workshop process. And in the workshop, we work through each of these systematically to identify the most relevant populations and impacts that relate to a specific proposal in a specific context. So on the slide is the headings from a checklist that I've used for this purpose in a planning context. And the impacts on the right-hand side of the slide are based on the dimensions in the place standard with a few adaptations. Health impact assessment uses different kinds of evidence, but in Scotland we're actually very lucky that we have very good sources of routine health data. So it's fairly straightforward to build a health profile for an area. The images on the right of this slide are profiles from the Public Health Observatory that are readily available online. Health impact assessments usually also use research evidence, for example, on the links between the kinds of changes proposed in health that have been shown in other similar developments. And the documents on the left of this slide are documents that our network has prepared that collate this kind of evidence on the health impacts of housing, transport, green space, rural developments and community venues. And of course all of these may be relevant in an HIE as a planning application. But this all needs to be combined with evidence about the values, views and priorities of the affected groups of people that I mentioned earlier. They will have an understanding of the local context, of how any recommendations from your HIE might work in practice locally, and most importantly of what matters to them. And the workshop that I just described is a good way to involve community members in a very systematic process in a very meaningful way. Most developments are also subject to a series of other kinds of assessments, such as these listed on this slide, and it's important that a health impact assessment doesn't duplicate these but draws on them to use the information they provide and show how this will affect health. I've mentioned the pre-application consultation on this slide because I think it can be particularly useful to define the screening or scoping stage using the workshop that I mentioned as part of pre-application consultation to avoid duplicating other processes. I think a health impact assessment of a planning application should be submitted in the same way as all of the other requirements that accompany applications, and this means it should be submitted by the applicant. But the person doing the health impact assessment needs to have some public health knowledge and skill to be able to show they've considered all the public health implications of the proposal. As I've already said, community involvement is important to identify the most important impacts, and this can be the stakeholder workshop that I've mentioned. I also think it's useful and important to involve public health partners in the local NHS board, not to do the assessments, but to offer guidance, support and scrutiny. I know that quite a few Scottish local authorities have some experience of health impact assessment, but as far as I know, West Lothian is the only one that currently has a formal requirement for health impact assessment of planning applications. I worked in NHS Lothian up until the end of 2017, and while I was there, I worked very closely with my planning colleagues in West Lothian on their planning guidance for HIA, which included revising the guidance. As we did this, we had a few principles that informed our approach, which relate to the things that I've been talking about. So we wanted to ensure that health impact assessments used a systematic way to identify the affected people and the most relevant impacts. We wanted to build it into existing processes rather than using a completely different way of doing health impact assessment to all of the other things that are required as part of a planning application. We wanted to use the evidence in a way that was meaningful and also proportionate to understand the relevant impacts. So we didn't want to just ask for a large amount of relatively undigested data and information. And finally, it was really important to us to work in partnership. One of the things that we agreed was that the NHS Board Public Health Department, where I worked at the time, would offer support by being able to offer advice and by scrutinising the HIA reports that came in. So this is the process that we adopted in our planning guidance. So pre-screening here means just determining whether the application is either a major development or a development that requires EIA, because our guidance required health impact assessment for, or at least the first stage of health impact assessment for both of those. Screening here means carrying out the workshop that I've already described to identify potential links to health, and we suggested combining it with pre-application consultation. If the screening identifies that there are very few relevant impacts or only impacts that are completely addressed in other planning documents, then the applicant can submit a report that outlines those and shows how those impacts will be addressed. This is reviewed by the planning officer and also an NHS board colleague. But if there's any uncertainty or any of those people think that further evidence is needed, the applicant then submits a scoping report which shows how they will address these impacts and which evidence they will gather, and then they carry out the appraisal and submit a health impact assessment report, which is also scrutinised in the same way. I thought it would be useful to show an example of a health impact assessment of a proposed development, and this is one that I led 5 years ago, which was before the planning guidance in West Lothian was revised, although it was in West Lothian. As I've said, it's the applicant's responsibility to carry out an assessment, so it would be unusual for a public health department actually to do a health impact assessment of a planning application. But in this case, you may spot the NHS logo on the report here. This was an application from the NHS Board for development of a former hospital site, so it was appropriate for us also to lead on the HIA. The assessment included a workshop with community council members, like the ones I've described. We then identified research questions for the impacts that we had identified and gathered evidence to address each of these research questions. And the evidence included a community profile with routine data and a pen portrait of the area, findings from interviews with key informants, and also some findings from reviews of relevant research evidence. So on the slide, it lists the key impacts that we considered and described in the report, and we made recommendations that related to each of these. This was 5 years ago, so it was before the 20-minute neighbourhood concept was recognised and discussed as much as it is now. But one of our recommendations at the time related to the importance of the site having mixed-use areas. This was a proposal for between 800 and 1,000 homes, So we identified that it was very important that it also had mixed use, partly to reduce car dependence and also, of course, to promote social capital. So it shows that the basic idea of the 20-minute neighbourhood concept was recognised even then. This next slide is an extract of the impact matrix, and it's not really for you to be able to read everything that's on the slide. It's really just to show how we laid out the evidence that we gathered for the health impact assessment. So we prepared a matrix like this, which showed for each issue the pathways by which they would affect health, what we thought the potential health impacts were, whether they were negative or positive, how likely we thought they were, and very importantly, which populations were affected by each of these impacts. The application that I led the HIA on was planning in principle. There has been a more detailed planning application since then with a further health impact assessment which followed the new guidance and reassuringly highlighted very similar impacts. So just to conclude, I think that more routine use of health impact assessment for planning applications could bring real benefits. Given the range of ways that planning decisions can potentially affect health, I think it's important that we use a systematic way to identify which are the relevant populations and health determinants for a particular proposal in a particular context. A health impact assessment really can be about as long as a piece of string, so it should be proportionate to both the scale of the developments and the kinds of impacts that are identified. And it can draw on the findings from other processes and assessments. I do think it's important not to duplicate these. In health impact assessment, we talk about using best available evidence, which means being realistic that we might not have all the evidence we would like, but in Scotland we do have a lot of data and evidence available in Scotland which can be used within an HIA. And it's important to use the evidence meaningfully to address the uncertainties about the impacts. There are really good opportunities for partnership with local communities. We're often keen to engage in planning, and the workshop I described can be a very meaningful and systematic way for them to do that. And also real opportunities, I think, for partnership between public health and planning colleagues, which I think could bring benefits not only for individual planning decisions, but also more broadly. I'm really enthusiastic about place and health, and I think that if we can make use of these opportunities, it can help create places that promote health and help reduce inequalities not only now, but for future generations. Thank you very much indeed for listening. This is my email address if any of you would like to get in touch with me, and this is the website of our SHAN network where you can find our guidance and resources. Thank you very much.
Thank you so much, Margaret, and I certainly recommend anybody having a look at that site if they're wanting to get a bit of a grounding on impact assessments. There are so many useful documents and reports there. It is very much worth a look. In many ways, the work that Margaret was doing with West Lothian Council was precisely what got me started on this very long journey now of pulling together more the ambition of health and planning, because it was certainly the first example that I had seen of somebody coming from health and going in and actually sitting in a planning department to get an understanding. And I realise since there are other examples of folks doing that, but the value of that in really getting to grips across two professions that talk in very different languages with initials for everything, it really highlighted the value for Margaret to be able to pick up on it by going in and actually sitting in West Lothian Council. Right, I'm now going to pass on to Helen Ashby-Ridgway, who's an Associate Director at Lichfields. And as I said, Helen is already involved in the preparation of health impact assessments within England and Wales. Obviously a different system. Public Health England and Wales have been up and running for a number of years, whereas we only just had the introduction of Public Health Scotland on the 1st of April this year. So as countries, they're ahead of us on the journey, but as we'll also find out on Friday when I join a session with people from both of those organisations, we have an opportunity to learn from what they've already done and potentially to take that nice step of going, oh, we could just introduce this straight away and do something differently. So I'm really delighted that Helen's able to join us to share what she's been doing and her learning for where we could actually sit back and take the benefit of her experience as we move forward and define exactly what we're going to do with health impact assessments, what that process will it continue as Margaret was referring there, and what might be some of the loopholes that Helen is already aware of. So Helen, can I pass over to you, and thank you very much for joining us today.
Right. Thank you very much, Irene, for inviting me to speak today. I think what you'll find is quite nice that a lot of what I'm going to say are things that Margaret has presented, and that's quite nice to know that the approaches, I suppose, are consistent, and the direction Scotland's going is consistent with what we've been doing in England and in Wales over the last few years. I lead our service, and I've developed our approach at Lichfields, and we've undertaken a range of projects covering residential, retail and employment, traditional employment types of developments. And we've learned quite a lot during this process, but I think that we're still on a journey. Adam, if you can turn the page, please. Thank you. This presentation, you know, as you'll have seen from Margaret's presentation, you know, the presentation usually can take an hour or more, and I suppose we're just going to cover the basics here, and perhaps in the Q&A session later on we can delve in deeper into some of the issues that we haven't gone into detail on, and perhaps draw out some of those experiences in England and Wales more. Okay, next slide, please. And the next one, please. For me, the absolute starting point of any health impact assessment is considering what we mean by health. What is it that we're meant to be considering? And the 70-year-old definition by the World Health Organization is the sharpest definition I've seen. It's clear that there are three aspects to health: physical health, mental health and social well-being. In terms of the latter, there are different definitions to social well-being, but I think they can be whittled down to the sense of belonging one feels with others. Next slide, please. You'll be familiar with this from Margaret's presentation. A health impact assessment is not, I repeat, is not only an assessment of where the nearest GP surgery is and whether it has capacity. I've seen this approach submitted with planning applications on many an occasion, even where the authority's guidance requires otherwise. Yes, access to medical facilities is important and indeed vital when you need the services, but the HIA covers an awful lot more. In the well-quoted Barton and Grant model, you can see that the determinants span across the natural environment, the built environment, activities, local economy, communities, lifestyle, and has people at its heart. Health impact assessments can be used for different purposes, and it is important that for us as planners that our focus is on factors that we can influence in the scope of our roles. There are some factors that are completely outside of our influence. We cannot change somebody's age, for example, or their genetics, but we can create places that respond positively to these characteristics. There are also many factors here that are directly and indirectly related to our roles, and HIAs look at these factors and consider how development or a policy can impact positively or negatively on the health of people within a particular area. HIA should look at the impacts of development or a strategy on the existing population and the new population who will be coming in to use those spaces. HIA should also consider whether there are any groups within the population who would be disproportionately affected by the development or the strategy. The session this afternoon, I know, explores the matter of health inequality further. Next slide, please, Adam. Thank you. And the next one. Linking up with Margaret's presentation, you'll see here that there are main stages of a HIA process. And I'd argue that there's no single best practice approach for HIAs in the UK. There are, however, a range of examples of good practice and locally or regionally adopted methodologies which follow roughly the same approach. And these steps will not be unfamiliar to anyone who does impact assessments on any discipline. Before delving into these stages a little further, I want to highlight a few things that HIAs are not. They're not crystal balls and they cannot predict the future. and they cannot be used at an individual level to determine if a single person or indeed a group of people will be affected in a certain way. Perhaps we'll come back later to look at that, at why that's the case. Next slide, please. Screening. No matter what type or scale of project, that it is necessary to go through the screening and scoping stages. These terms are familiar in environmental impact assessment, but they're helpful for HIA too. Screening is a process of deciding whether a HIA is needed in the first place. Most authorities in England and Wales who require HIA for a project already dictate the screening stage, either in policy or through their validation documents. This is usually through the setting of a threshold for a type or scale of development above which HIA is needed. If this isn't in place, we need to look at the context for the project and the potential effects that the development might have. Where HIAs are needed, we then need to consider what type of assessment process that should be followed. There should not be a one-size-fits-all approach. Next slide, please, Adam. Thank you. There are different levels of assessment, and it's important to recognise there is no standard in name either. At Lichfields, we undertake a broad range of assessments, either to suit the project or in response to the requirements of an individual authority. There are lighter touch assessments, typically, but not always in the form of a template approach. These are usually desktop assessments which are carried out at the end of the design process to assess the final project before submission or the determination of the project. There are also more in-depth assessments which involve an iterative design process whereby the HIA is carried out alongside the evolution of the project and interventions are made to improve the assessment conclusions. These embed mitigation measures to improve the determinants of health of the final project. Even within these two broad approaches, there can be a significant difference in the nature and level of assessment that is followed. The scoping stage helps us to decide which approach to take, which determinants to assess, which geographic areas need to be looked at, and whether there are population groups that will be particularly vulnerable to the change. Next slide, please. As you're becoming to realise, there is no one-size-fits-all approach when it comes to HIA. The level of detail assessed will depend on the scoping stage, but it will also be a function of how much detail is available for the project at the time of the assessment. A full application is very different to an outline one, where principles can be established, but the final details are some way off. We also need to consider both construction and operational phases of development. And in some cases, it's also appropriate to look at the decommissioning phase too. The judgments made in a HIA need to be underpinned by evidence. This is a whole seminar series in itself. Importantly, we need to be able to justify our conclusions in the assessment, and understanding how the evidence is to be used is an important aspect of the process. In terms of outputs, it is, I would argue, impossible to conclude that as a result of the development, Joe or Josephine Bloggs will in 10 years' time have X condition or Y improvement as a result of the development. Instead, we need to look at the potential that the determinants assessed have the direct or indirect ability to result in a change to the group as a whole or subgroups within that main population. Next slide, please. For larger scale or complex schemes, the HIA process often needs inputs from a variety of people. These may include those who know the geographic area, those who understand the populations and the inequalities therein, those who have the specialist knowledge of the potential impacts of the development. For projects where stakeholder engagement is valuable, we invite individuals to participate in workshops to combine understanding and knowledge in order to prepare a robust output for the decision maker. My objectives for the stakeholder engagement process is to seek out agreement on the methodology, the scope, pathways, evidence and outputs. It's important that these sessions are focused and are not a repeat of the wider planning consultation process, which you can find then distracts from the matter that you're dealing with. From experience, it can be challenging to bring people together in these forums. People are busy, and in some places the number of projects that require such interventions could be numerous, and therefore policies that require stakeholder engagement as a mandatory part of the process should recognise these constraints. Next slide, please. Either during the HIA process or as an output of the desktop assessment, mitigation measures can be recommended to the project team. At the outset of the HIA process, there should be a clear objective set. Do you want to make the project acceptable in health terms, or do you want to make the project better? Mitigation can be embedded through the design process, even where the original scheme has no adverse impacts. The majority of the measures I tend to recommend are otherwise good practice urban design principles or good practice planning principles. Often a fresh pair of eyes looking at the project from a different perspective allows tweaks to be made to substantially change the conclusion of the assessment. They are generally not onerous, but are much better received if they're part of the design process than left to the end. Any requirements need to be grounded in evidence with clear pathways for effectiveness. Next slide, please, Adam. Where possible, I like to recommend easy wins. In recent projects, these have included suggestions for encouraging people to use green spaces through the use of signage, placing picnic benches and other such features to encourage social interaction during lunch breaks in business parks, reducing the amount of time diversions on public rights-of-way are in place during the construction process, opting for alternatives that don't discourage people to stop their already healthier habits of walking, cycling, etc. Measures that help one group of people often help many more. I would note that any measures that are introduced or recommended must be related to the development proposed and within the control of us as our role as planners. 2 slides on, please, Adam. Thank you. And one more, please. The question is, are we still finding our feet? I think we are. Local authority knowledge and confidence and collaboration is growing. It is key, absolutely key, to understand the proportionality needed in the undertaking of a HIA and how that relates to different types and natures of schemes. We're also finding that developers are starting to understand the process and why it's important. Somewhat of a carrot and stick here where the local authorities are introducing requirements, but many of our developers as well actually are understanding that in creating great places, these measures that are being introduced are able to help them achieve that. Irene has talked about establishing best practice guidance, and Margaret has referred to West Lothian's example. I think this is really important, although having a national version rather than individual local authority versions would help massively. And as I said, in terms of proportionality, we need to avoid the everything but the kitchen sink approach to undertaking HIAs. And the final slide, please, Adam. Thank you. So, 5 key messages to take home. Scoping is important, as is proportionality. We need the evidence to underpin the assessment, and we need to understand properly how we can use that evidence, and perhaps it's something we can talk about a little bit later on, Irene. The assessment outputs are often, and more often than not, qualitative. You can't say, as I said earlier, that X number of people are going to be affected in a particular way. It's not possible to do that when you don't have a house-by-house assessment of what the existing conditions are, and you also can't predict 5-10 years in the future as to what that change is going to be at an individual level. And what I would say is, where possible and appropriate, we adopt a collaborative approach to producing the HIAs. Thank you very much.
Helen, thank you very much for that. It's encouraging to see similarities there. I think when we chatted a week or so ago, we hoped that there would be similarities that would come out between the 2 presentations, and that is reassuring that there certainly are around social determinants and so on, and also quite a lot there around the process also. We've touched on a few, and in your conclusions there as well, Kirsty, about that knowledge, confidence and collaboration with local authorities and with planning authorities. I wondered, what is that capacity? How have you felt that capacity has developed because obviously, and I'll come to Margaret in a moment on the same question, what is the capacity within Scotland, within planners, to actually know what to do with a health impact assessment? But I wonder what your experience has been of that, Helen. Oh, you're on mute, Helen, sorry.
Yeah, we can hear you. Yeah, you're a bit quiet though, if you just turn the volume up.
Okay. Irene, our experience has been that it's been very varied between local authorities, and I think there is also a difference between Wales and England. In England, for quite a few years now, we've got a Director of Health sat within the local authority, and the idea there, in part, was to share the knowledge between the planning department and the Director of Health team. We're finding whether that's happening or not is very varied between each local authority when our applications are going in. The Director of Health isn't automatically consulted on a vast number of applications that are relevant, and within the authorities they don't have the resource to critique a HIA either. We've got one or two authorities where there's a requirement for HIA, but the planning officers don't ask for them because they're not sure what to do with them once they've come in. I won't name authority names. So there's a bit of a disconnect there in what's being asked for and what the authority is able to do with the HIAs once they're submitted.
Public Health England have done a lot of work around this and going in and working with planners and health practitioners, pulling them together. I went down and attended one of those sessions. Have you been aware of those happening? Is that something that you've seen a benefit from, or not so much been aware of them even taking place?
So I'm aware of the Welsh Health Impact Assessment Support Unit who leads in Wales, training officers in the London boroughs, for example, and London certainly leading in terms of HIA requirements. So we know that that's been done, and there are other examples of authorities. For example, Worcestershire is really ahead of its game. South Gloucestershire has its own health impact assessment officer who looks at applications, and other examples such as Torquay, they have examples where they have been working with health professionals to progress, I suppose, develop their knowledge. So we know that that is happening. I don't think it's happening across every authority at the moment.
Lovely, thank you. It's a different circumstance, isn't it, where certainly in the English authorities they have, as you say, a Director of Public Health within the councils. Scotland has gone a different way, and the local health boards continue to exist as separate entities. So even more of a challenge perhaps. What are your thoughts, Margaret, on how we move forward with that and the capacity?
I think I would agree that in Scotland it does vary around the country. I think there is much more interest in and awareness of the importance of planning decisions for health and of place for health much more broadly. So I think there is definitely an appetite for much more partnership work between local NHS board public health departments and our planning colleagues and local authorities. And so I think there's an obvious capacity issue at the moment with the pandemic, and public health departments are quite busy with the acute response to that. But that doesn't mean that there aren't people who are also interested in and willing to work in partnership on other issues that are also related to the pandemic. So the pandemic has impacts on place, and place has impacts on people's susceptibility to COVID. So I think Capacity does vary, but it is something which is being seen as much more important, and it's something which I think we need to promote and support much more at a national level and at a local level. I think the training that Helen mentioned, when I was in West Lothian, we also ran. I mean, it was training for me as much as for my planning colleagues. It wasn't me running training for them. It was joint. It was much more joint discovery. I definitely learned as much as they did about the planning system, which although I had worked in planning a little bit before, I really didn't understand a lot of the constraints until I worked much more closely with my colleagues. So I think it's a joint thing, and I think what we need to promote is much more of a partnership approach. Angela was talking on Monday about a health and all policies approach and working with different NHS board colleagues on different issues, and she talked about how different people will bring different public health colleagues will have different areas of expertise that they can bring to the table, and it's important not just to have one link person, but actually to work with the department as a whole. And I think that's the model that we should be looking at. We should be looking at much broader partnership working with planning departments and other local authority departments actually, but planning in particular.
Yeah, I know that in consultation with certainly development planners across Scotland, they have three reasons. Helen alluded to them. They have three reasons that they get in touch with their local health board, which will be assets such as the Bangor hospital site. It will be that provision of health facilities, and then there will be that overall public health and the role of place of those social determinants. So it may well be that it's three different contacts. I do tend to find when folks say to me, oh yes, we're working well with our local health board, it will be in one of those areas and very infrequently in all three, though it does happen in all three areas in some parts of Scotland as well. So before I will go down into, there's a question there about the value for smaller developments as well of an HIA, but I wonder actually about that higher level question about, let's start up there at the local development plan level and a health impact assessment role of what is the role of the local development plan within that. Helen, if I could come to you first, because it would be good to hear what is happening in your experience, and then Margaret, if you were able to share your thoughts on the role of local development plan within all of this. Helen, I'll pass to you.
So doing HIAs for local development plans is not something we've been involved in directly, either for councils or in terms of critiquing them either. What I'd say is that if where they are being undertaken, they're being undertaken as a side part of the process, I suppose. I think it's absolutely clear that a full range of determinants of health are now being brought into the actual policies. But I suppose what isn't being done consistently is then testing those policies against the I suppose all the other options, and it comes back down to proportionality again. The planning is very complex, and you don't want to go down testing every single option. It's just not feasible, and you need to deliver local development plans. Our planning is based on a plan-led system, and you need to get these processes through. So I'd say that again, it's quite I wouldn't say hit and miss, but I'm not sure the health impact part of the process is central to the preparation of the local development plans.
For the local development plan to set the higher themes that an HIA should be considering, the kind of overall themes, although every site will have its detail.
Yeah, it's difficult really, because like you say, every site will have its own considerations, and the risk of setting themes, certainly in a policy, a single policy, it means that either you are being narrowly directed to dealing with just a handful of issues perhaps, or you might have other authorities who say, well, we've listed out 12 different determinants and you need to look at 24 different issues within each of these 12 different determinants for every single application. So and that is not proportionate for a lot of schemes. It will be proportionate for some schemes. So there is a role for the development plan certainly to set a policy, and where it's appropriate to set it, requiring health impact assessments to be prepared for certain types of applications. But I think after that, it needs to be down to the screening and scoping process to determine what type of assessment needs to be undertaken and what the scope and nature of that process will look like.
Thank you, Helen. So I know the conversations that we have had within Scotland have been around, very high level themes in a local development plan, but then yes, into scoping for the actual detail of a site. Margaret, what are your thoughts around that and the role of the local development plan?
I think it is really important for public health to engage much more with local development plans because they set the whole framework for the next 10 years. I have been involved with a few local development plans where we have carried out a very similar exercise to the stakeholder scoping workshop that I described earlier, but on the local development plan. So we've carried out the scoping to look at what are the health issues that are most relevant, we think, for this particular LDP. And I think that's quite a sort of fairly quick way to identify what are the key issues, and you can then go do a more detailed assessment if that's proportionate and going to be helpful. But you don't always have to do that. Often just bringing people around the table to say, look, here are the critical health issues for this area. This is how the local development plan relates to them. These are the populations and impacts of the LDP. That in itself can raise awareness and can lead to further partnership work. And I think often it's about the ongoing partnership, taking a health and all policies approach, not just doing a one-off exercise and submitting a report and then going away. It's really how can we build sort of ongoing partnerships so that we're working on a much longer term. So I think the scoping exercise can be a really good way to highlight what are the main issues that relate to a particular LDP. And Irene and I were both involved in an exercise very recently where we've looked at scenarios for Edinburgh's LDP, one of which was a 20-minute neighbourhood scenario and one of which was a traditional, more homogeneous, low-density building, much more on greenfield sites. And we carried out a scoping exercise very similar to the ones I've described on both of those scenarios, and we've written that up. It was actually launched just this week. So that's an example where we have carried out that kind of exercise to feed into an LDP, and that is effectively that is an HIA scoping. We also identified some research questions from that exercise, and we're looking at how we can pick up. We've got various colleagues working on how we can pick up those research questions to have so that we can feed it in. We're not really calling it a health impact assessment because I see it as a longer term process of partnership work rather than just a sort of one-off assessment that we then complete and go away. But I think that's the kind of process of partnership work I would like to see much more, is using a health impact assessment approach. It's using health impact assessment thinking about what are the broad range of impacts and can we narrow it down to the ones that are relevant, but it is definitely building partnership.
Hope that answers Jo Winterbottom's questions as well there, that it is looking, yes, down at a kind of a national approach, but then it has to go down into the local detail, but that there is a possibility of looking there at that local development plan up at that level and doing that sort of assessment, but it is a conversation rather than some one-off assessment. I think there's also, for ourselves in Scotland, we have the National Planning Framework will become part of the development plan, so there's another layer of opportunity for us with a very different setup within planning in Scotland. Margaret, you mentioned evidence there, and Helen, you said that you alluded to wanting to come back to say a little bit more about evidence that can be backing things up. My experience coming in as a planner into a health practitioner world is I don't know what I don't know about evidence, and I am learning what there is and what value it can be to translate it across and through into planning, because there is so much there. What was it that you were alluding to, Helen, when you in your presentation?
I think what we struggle with is that it's quite difficult. Like I was saying, you can't look at a particular area and say, this is what's going to happen to this based on this particular evidence. You might have evidence that suggests something might happen. So we know that things like going up for a walk is good for us. We know it improves cardiovascular disease, it improves stress, it improves backache, it improves a whole series of medical conditions, and that has knock-on effects on the economy, directly or indirectly. What's difficult though is that we can't then translate that evidence and apply it to a particular group of people and say that that particular group of people are going to be so much better or so much worse at the end of the development. You've got to have sort of, I suppose, faith that the general evidence that's there can be translated, or the direction of travel from that evidence can then be applied to this development. We know that, for example, trees are really, really good for our health, directly and indirectly. But a lot of the studies are based on massive woodland sites of hectares and hectares of woodland, and we can't then translate, well, what does one tree mean for a particular group of people? Or if you put a tree-lined avenue in, what does that mean in terms of a figure, a quantitative figure, in terms of improvement on health? And that's just not possible. And I think the other thing that it's worth bearing in mind is emerging evidence on health. It takes a long time to develop evidence on health. And, you know, we can all see it with what's happening with COVID. It's difficult, it's complicated, it's hard to separate out different effects that are influencing the outcomes and people's outcomes after having COVID. But then there is a lot of exciting evidence that's coming out that can be relevant to us as planners. There's evidence around birdsong and how good that is for us. But I'm not sure yet whether we've seen any guidance, for example, in NICE, where they might say, well, let's introduce woodlands around our areas that might have birdsong because that's really good for our health. So I think things take time, I suppose, is what I'm saying. And it's exciting, but the question mark is, would we use that evidence as part of underpinning a health impact assessment now, early in the process? I think it's complicated.
Lovely. Thank you.
Thank you.
Oh, gosh, I keep hearing myself. Full answer. I'm going to pass to Margaret as well. What I have certainly been learning over the past year is that it isn't, and it's a little bit of what I think you were saying there, Helen, this isn't just about evidence, it's the experience that sits behind knowing how that evidence impacts. And I know that that's certainly what sits with a lot of people in Public Health Scotland and that I am learning, and it links up with what planners have been doing with a bit of a gut reaction, and bringing the two together is very, very powerful. Margaret, I'm going to pass back to yourselves finally, because we only have about a minute, to a little bit on evidence, but there's just a final thing that Helen brought up in her presentation about whether we are simply mitigating a negative impact, or are we seeking in a health impact to improve, even if the overall impact was fairly balanced? Are we always what is your gut feeling of what we should be seeking to do in a health impact assessment? All of that, simple question in a minute, Margaret.
Definitely enhance the positive. It's not just about mitigating the negative, it's both. And we would definitely look in health impact assessment to both mitigate negative impacts but enhance positives. When we're creating a place, we can create a healthy place that will last, as I keep saying, for many generations. And it is really, I really do think we want to create the best place that we can, and that means enhancing the positives. In terms of evidence, when I first started working with planners, they often said to me there isn't any evidence about health, and I was astonished because I thought there was loads. I think we do have lots of evidence. It is important that we use it meaningfully and critically. So I think it's about, you do the process where you identify the impacts, you see what is it we need to know about these to inform what we're going to do. You then use that and apply your evidence to it. I think it's important we don't just throw in lots of data and numbers and research evidence. We use it in a very critical and meaningful way to say what is it we need to know about this that will inform what changes we might want to see to this application. So I think it's about very much that process of being critical in how we apply it, and also being proportionate, as we keep saying. It's not about collecting every last piece of evidence you possibly can. It's about using it in a proportionate way, depending on what the application and the impacts are.
Thank you.
Definitely, it's about enhancing positives.
Very succinctly put. I think The journey ahead of us around that evidence and linking up was really highlighted just about a month ago, where we were doing work with planning authorities feeding into the digital planning review, and it was a consistent thing that was identified by every authority was we're being asked to deliver a new outcome on health and reducing inequalities, but we don't have that evidence. That's the biggest gap that we can identify, and I know it's there. We do, as you say, Margaret, we just need to join that up. We are out of time, as happens with every one of these sessions, so I will thank both Margaret and Helen for sharing their experience and their perspective to what is the start of a journey for Scotland, and I hope that we can continue and learn from what our neighbours are doing and what they've already developed, and Helen certainly helped us with that, and that we can continue to, on that journey, work together. It's one of the biggest areas for us to be coming together upon. People don't work together unless they have a reason. Health impact assessments are coming our way, so there we have our reason to start picking up the phone and talking to each other, as Angela Scott was recommending to us earlier on in the week. Thank you very much to both our presenters. Thank you to everybody for listening, and go safe and goodbye for now.